global stage. What are we doing today? What should we be doing tomorrow? And how will success be judged? How will impact get judged? That's really what I want to speak to. I will start with some facts, but at the end of the day, I really want this to be a thought exercise where we are saying, what should we be doing next? And there is so much that is being done. I think if the Institute puts the data that they have together, you can actually make a very good cost-effectiveness argument for this approach, because everybody refuses to do this approach, and when you discuss it, what everybody always says is, it will be too expensive. It will be too expensive. Thankfully, President Trump has decided that his people are more important than our people, so now we're having to think of our own solutions. I may find out that these things need not be as expensive as we think we are, especially if we harness our communities. So I wanted to start by defining public health. When we come to practice public health, we will usually do it as one of these four itineraries, or one of these four models. Most people in the room may fall into the first category. Or some people in the room, everybody can do public health. Bring whatever you have into the public health space. You're an artist. I have a friend who is a lawyer. She does prison reform, prison support. She actually sets up a foundation. They go to prisons and they talk to people. You know, prison is a place for the poor in Nigeria, if you've ever been to a prison. All you need to be in prison is be poor. That is the first indicator for being in prison. You can be walking on the road, police pick you up, you can spend 5 years in jail, very easily, especially if you're poor. So what she does is they just go there, talk to people, and in some cases they're able to make a case for their innocence, and they release those people eventually. That's public health activity. A lot of us are disciplinary public health practitioners. We trained in public health by training in community medicine or community nursing or something else related to that. There are public health agents here who are government agents. They are probably the most powerful people, you know? They're the ones that control the budgets. They're the ones that set the government's agenda. And they're the ones that strategic level meetings whenever they take place. And ultimately, all of us, if we live long enough and become big enough, will practice public health by eminence. We'll graduate into it, you know? Professors of pediatrics will become professors of child health. Professors of obstetrics, professors of maternal health. You know, that's natural. But within these iterations, it is important to identify what our role is. And I think a lot of the challenges we've had in the Nigerian health system is, I won't speak a lot about this. Dr. Shumakinwa has talked about it. But I just want to highlight the different subspecialties that we have in public health and community medicine, especially if there are younger people here who are thinking of where to go into. The big two is epidemiology and biostatistics. That's the core. Everybody learns that. After that, the biggest four areas which account for the most of the problem, the most of the resources, depending on where you look at, are health policy and management, if you're looking at it from a governance, management, coordination standpoint. Reproductive and family health, if you're looking at it from a service delivery standpoint, most of the people who go to health facilities go for reproductive and family health related issues. If you run a health facility that doesn't have that, you haven't started. Environmental health, because that is the biggest independent determinant of human health states and living conditions, right? And then disease control, which is the primary element that we are interested in as physicians and in order to stop or prevent epidemics. Now, the other five are health, education and promotion, occupational health, public health, nutrition, rehabilitative and social medicine, international health. And then we can talk about emerging spaces like mental health, dental health, biodiversity and nature conservation, and sustainable development. So these are all areas of practice that exist in public health. And as early as we mature through, these are things that we can get into. I put the Alma Ata Declaration here because I wanted to highlight something. At the core of everything it does is the idea, especially now, is the concept of community participation. Now, we talk about community participation a lot, but I think it's important to think about and remember that there are different levels to community participation. At the lowest level is information or tokenism, just we want to do this, that's just all. And very often, community members are captive, especially if you have incentives. Especially if you go with money or you have soap and other things, people will participate just because You brought something. So that's the lowest level. But more important than that is from going through informing, consulting, involving, collaborating, the end result is actually that community participation ends in of beneficiary capacity and community ownership. That communities actually set the agenda, communities actually initiate projects, communities actually mobilize resources and get to the point where even if external funds, resources, programs come, the communities can come and say, this is not our priority. If you're bringing those resources, this is how it's going to be channeled. And at the end of the day, these community activities should alter the path of people's lives. Someone that was a local government NURTW secretary, just running around organizing meetings, because he now learns how to maintain a spreadsheet, write minutes of the meeting, improves his education somewhat, he now becomes someone who's a proper manager, and can sometimes even ascend to a higher level. At the end of the day, this is what community development should be doing, altering the trajectory of people's lives. And at the core of all that we need to be doing, we should always remember the concept of social mobility. All that we do needs to alter that. Most of us, at least my father, in speaking to my father told me that if he hadn't been smart in school, I would have been born on the farm. So I won't be this tush-seeming boy that Professor Johnson has been yabbing for becoming very fat since after COVID. I would have been a farmer. There was a day we went to the village and I saw one farmer. So the guy now said, Omole pele. The guy was my dad's classmate. So the guy was telling my father that, you see, you went to school, you became a manager in Nepal, you left us, you see, we are in the village. That was the day I realized that I could have been one of the wretched people that I sometimes look at and think, what are they doing with their own lives, A lot that happens in life is happenstance. Okay, this is the definition by Professor Suzu of what community medicine is. Community medicine is medical practice. We are practicing medicine. And for don't think we are practicing medicine. We practice medicine because we are doctors, right? And our postgraduate training makes sure that we can maintain that. We can practice like non-specialist generalists at the minimum, right? So in our field, we apply all the knowledge of clinical medicine and public health knowledge, and we use it to protect, maintain, and optimize health. Ideally, in the best examples of our work, we would do it in a place where we have some kind of statutory responsibility. It's a place that is defined by law. It's a place where we have a legal responsibility and we have powers. And this is expressed most clearly in the Office of the Medical Officer of Health, which Dr. Shumakinwa has spoken about extensively, so I will not do that again. So this is just a small timeline of different things that happen in establishing community medicine and nursing practice in the UK. And it is sad that the UK that developed that model has now abandoned it and drifted into what is more likely or more akin to a vertical public health approach, where community medicine functions have been delegated to the trust. And I'm sure all of us are aware that there is a rolling conversation every year about the challenges of the National Health Service. And in developing our systems, I think that we should be asking ourselves, what should we not copy? Which is one of the personal reservations I have with the National Health Insurance, NHIS, as we seem to roll it out. I think that very often, I can talk because I'm not a specialist in that space, so, right? I can yab them. When you're on the outside, it's easy to yab the people who are inside. I think that we copy a lot that doesn't work very well. If you copy health insurance models from the US has one of the worst health systems. It's a developed country with the worst health system in the world. So if you're looking for what to copy, that is what you should not copy, because that's certainly what doesn't work, So those functions have been rolled up in the UK but the example from this university, from this institute, shows that it can actually be delivered here. And I think there's a lot that you can say about revamping things in Nigeria going forward. I put up the health plans and initiatives that have happened in Nigeria. These are from the Lancet Commission paper for 2022. I think people may be interested in it. The second national development plan, they didn't focus on health, it was on other things. By the third national development plan, there was a mention of basic health services, the BHS scheme. Professor Suzu was part of that scheme. He tells us about his NYSC experience, which has gone a long way in shaping him into the rebel he has been for over 50 years. The fourth National Development Plan, 81 to 85, is what we actually articulated primary health care, Olikoye and some Kuti's work. The 88th National Health Policy, Future Health Systems, from then you see elements of the Bamako Initiative, establishing National Health Insurance Scheme, and the National Primary Healthcare Development Agency. Now, 2014, very important, the National Health Act and the Basic Healthcare Provision Fund, which is a big deal in this conversation that we're having. And I'm going to try to say a bit more about that. So this is just an outline. Now, the Ibarapa program. The Ibarapa program predates primary health care, the articulation of primary health care. You know, history is written with the benefit of hindsight. Everything we are doing, we're making history today, right? So it is in 10, 15 years' time that someone is going to sit down and document it all and then write it as if it happened in one very seamless manner, you know? It was different things. Prof coming to do sabbatical, he being unhappy with us about not listening to him, you know, people here being, oh, let's try to, you know, so history doesn't happen in a linear pathway, right? When our program was established in 1963, a model where the federal government provided through the university outside funding in 1973, we didn't get a lot of money from the university, and sadly we have fallen behind what the University of Medical Sciences is doing in Ondo. That is the truth. I'm coordinator of studies, right? But right now, we still serve as a community training site for the college, university, and affiliate bodies. And when I go back, I will go and speak to the provost and demonstrate to him how University of Ibadan, when we say first and the best, in this one, we might be the first, but we are no longer the best, you know? Now, this is a plan for the physical campus of the Ibarapa program in Ibora, 42 hectares. Professor Su was director when we came up with this physical plan. And if you look at it in detail, sorry, you can't see it so well. The entire area is mapped out into demonstration farms, opportunities to reclaim waste and turn it into energy, hostel accommodation, you know. So it's a very extensive tract of land and clear plan, but this has suffered for a lack of resources to execute it. Now, what is the current situation in Nigeria on some of the indices that we should be looking at for our impact? Remember I said that this is all about standards of living. And part of what we should be defining is what should we be looking at. So just to situate this in reality, before I get into my thought experiment, I brought some indices, and I know, you know, university people, professors, they like seeing numbers, right? So a few numbers for us to get excited about. So this is from the NDHS 2023. This is child mortality indices in Nigeria. And we can see that neonatal mortality, about 28 per thousand, under 5 mortality, grim figures, almost pretty much approaching 10% in places like Northeast, Northwest. And then the shocker, Southwest has the best figures, and the figures from Ondo State are nearly unbelievable. I think we should give ourselves a round of applause. This is not the work of the University of Medicine and Medical Sciences. You know, you only covered 3 words, but this is just to demonstrate that the investment that the Ondo State government has made into maternal and child health services produced an outcome, and a significant outcome, you know. If you look at these numbers without knowing the background, you think that, like Prof, when you did that tobacco survey, when you see numbers like this, you know, it's either something spectacular happened or the survey went wrong. In this case, something spectacular happened. The numbers are astonishing. And you can imagine what these numbers might look like if this community health model ends up being rolled out across the entire state. From having satellite wards, you're able to take over the entire local government. After taking over the local government, you can take up adjacent local governments until you cover the entire local government. And one thing I know about community people is we like to compete. Once you need to frame this in a way that these people are getting this advantage that you are missing out on, you know, then people's ears perk up, and there are resources sometimes even where we don't think there are. This is a graphic from Data Fight that shows health facility availability in Nigeria. Ondo State is somewhere in the middle, below the median. But this is kind of data that can be misleading. A lot of the better picture from the middle belt is really because of the way people are spaced out. When people are spaced out in wide areas, you need a lot more facilities to cover them, So this isn't really the best indicator. This is health insurance coverage, uniformly poor. The best states, FCT Boeing, barely boasts 10%. This is data from 2021 or 22, I believe. Now, I tried to compile some indicators from the NDHS to look at Nigeria versus Ondo states. And on most of the metrics, because of what the northern part of the country does, the Southwest performs better, pretty much as a matter of routine. So teenage pregnancy, 6%, full vaccination with basic antigens in 12 to 23-month-old children, only 51%, well below the 80-90% thresholds that you require for herd immunity. When you think about it, about being fully vaccinated, it drops to 47%. Non-communicable diseases, proportion of people, women who have delivered by skilled birth attendants, good, could be better, 74%. Ever having done a blood pressure, been diagnosed with a high blood pressure, 42% of males, 37% of women have been tested, 11% of males hypertensive, 5% of females. Getting blood sugars done, 15% of males, 25% of females. And here we begin to see the picture of men get left behind out of the health service. The women show up. The men are too busy working, so the men die and the women continue living, and nobody talks about this. We need to start having male-focused programs. We are the endangered species. Okay. Okay. Now, the aim of all that we're doing and saying is, I believe, to get to this goal. To leave things better than we found them. And I think the goal at the end of the day is for the University of Medical Sciences to create a high-quality, innovative statutory community health program in Ondo states, where you can have a statewide community health framework with comprehensive coverage by community health nurses and midwives, supported by properly resourced medical officers of health and assistant medical officers of health, with health system linkages up through secondary to tertiary health care that has robust health insurance backing it. I think this should be the goal. Having started these pilots, I think ultimately this is what the university and the teaching hospital should be measuring itself against and saying, how close are we to doing this? The university, through the institute, will have certain roles. This is my thought experiment, right? So this is just me thinking about what the roles should be. I think the university will be a knowledge repository and driver, so a place that situates knowledge and drives the questions, answering the questions that need to be asked. Listening to Dr. Shumakinwa, one question that kept popping up in my head is, what is the cost side of this? What's the cost effectiveness of this? What's the cost benefit of this? If you can demonstrate that this is cheaper cumulatively than vertical public health outreach foray programs, then why are we doing that? Ultimately, I think the institute needs to be a maven, a nexus that connects different departments in the university to the governments and the community in delivering on this community service model. What are some of the weaknesses and threats? Once more, I'm an outsider. This may be wrong, but just what I know of how Nigeria works. You always get the question, what is the perceived cost effectiveness of this? It may lose you political will. People think it's too expensive. You can probably answer that question. Competing needs and resource limitations, and there will be capacity challenges, especially at local government level. There are always capacity challenges. What are some strengths? As has been demonstrated from the presentations, there's strong political will and institutional capacity. There's a cohesive body of stakeholders. There's legislature on local government funding. More money will be coming to local governments very soon, if we believe what is said in the news. And there is diverse capacity here with the erudite faculty, the vice chancellor, the different directors, who have connections to other local and international networks, that can contribute to enrich, develop, and improve this program. And I think when the papers from this project begin to come out, you are going to get, these won't be the papers you write and nobody responds, These are the ones that get cited and you get a lot of letters written to editors. So I'm really excited to see that input. In thinking about the future, what are some of the tools of the future that need to begin to be deployed within this activity? Electronic medical records and the capacity for big data. If this data is still on paper, entering on paper, it's probably will die on that paper, Telehealth, innovative social solutions, artificial intelligence tools. At the West African Conference of Physicians last year, one of my colleagues presented a paper on the National Health Management Information System and the problems with using the information from it. His research showed, I think we can think about. At the end of the day, this is one of my own guiding thoughts. I'm sorry, I'm not one of the unreasonable people. I'm a very reasonable person, so I'm not one of the people who changes the world. Professor Susie is a fairly unreasonable person. After leaving Ibadan, a lot of people would have called it quits. University is a place where people should be able to challenge their teachers, and then you go and prove that what you said is correct. Ask questions, listen, and observe for the answers. Be willing to embrace trial, and be willing to embrace change. I brought some questions from some of the things I've read recently that are relevant to community health in a broad sense, not currencies, such that people can trade without having money. Do you have labor? Come and wash my car. I will give you food. So you have resources within the communities. You stand and you see everybody just sitting around. What's it? Kosovo? But everybody is breathing. You have skills and capacity. I have needs. You have skills. So can people begin to exchange these skills? And when the economic downturn of the early 2000s happened, this is some of the stuff that happened in Greece. People learned to think beyond the existing systems. Question for those in social sciences. Every few days, you see people killed for wealth rituals. Do wealth rituals impact business success? We will all say, should we take a vote, yes or no? I won't ask. So what's the question that can we, as a tool to build empathy and community virtue? Can we identify successful techniques, things within our local space, treatments, methods, counseling methods that make traditional health providers seem to be more effective than orthodox ones? They keep their clients for longer, they believe in them, they maintain what they are told, So I think these are different things that we can think about, and doing that, maybe we can transition our present into a better and a glorious future. Thank you for your attention. These are some of the sources I consulted if you'd like to read more about this. Thank you so much.
Please a round of applause for Dr. Popola. Before we move to the next item on the agenda, I want to respectfully recognize in our midst this afternoon the Yongede of Epe Town, Ondo East Local Government, Oba Akinkwade III. Please a round of applause for him. You are welcome, Javier. Now we move to the next item on the agenda so that the whole event will not be like a monologue. We'll take responses from the audience, and I know our speakers also will respond to some of these things, so that at the end of the day, we can have things to take away from this symposium. And to do that for us is a senior lecturer with the university, also a consultant public health physician, Department of Community Medicine, Unimed/Unimed THC, Dr. Victoria Oladoyin. Please a round of applause for her.
Thank you, PRO. I want to appreciate our speakers for today. Dr. Nice seeing you after. So why this symposium was put up was to look at how to integrate medical and health professionals into community-based healthcare system, especially looking at the one being piloted by the Institute of Community Health, the ICH A&D here at Unimed. So I could see a lot of professionals all around, from our medical professionals. I can see pediatricians, people from O&G, I can see the internists, the nurses, people from public health, all over. I can see so many people. If I didn't mention you, I can see health information management, different people, different, but even the librarian is here as well. So I can see so many people. So it's time to, even including the community members. So we've had a lot from our speakers today. So your thoughts, and how do we move from where we are currently? I love the closing remark when Dr. Pokuola was rounding up. He said we should from where we are, and also if you have questions for our speakers. So now is the time. I think I want us, if you have questions, we'll take it in batches. So this will take about 20, 30 minutes. So we'll take it in batches. So I want us to just signify by raising up our hands. We'll take in batches and they will respond. So I'll give number. Yeah, Dr. Aladeni, so that's number 1. Yes, my CMAC, Dr. Akimbodewa, that's number 2. Yes, Dr. Odipe, that's number 3. Okay, so while others are still warming up, so we want to start with Dr. Aladeni.
Who has stake, in this business. However, there is something that I observe. The discussion on the gown going to the town is not new. It's been an age-long discussion. And I remember in 2011, Professor Adeshegun Fatusi, when he was in Ife, invited us to also participate in this discussion. But again, looking at what we have discussed here, I still see or observe that we are still doing the same thing. And it appears that if we continue like that, personally, I feel that we may not be making progress. Number 1 is that we are discussing this community service, community health services, as a different component, as an isolation from the entire health system itself. The community health system is an integral part of the health system. I wish I could project. Professor Fatusi has a diagram on the health system building block. And at the center of that building block is the people itself, which is the community. Community, irrespective of whatever group and interests that they have, all communities become part of that community, that system. And all of the building blocks of health system must speak to that particular component. Otherwise, it will be a failure. So community services or community health itself, is an integral part. And we have to discuss it, around the context in which it exists and as it relates to all other systems as well. The health system, yes, of course, is the bigger umbrella, but then it must speak to this. And interestingly also, I felt that we should also have laid some emphasis on the good work of Donald Trump. Because for the first time, it became clear to all of us. Interestingly, I'm one of Professor Fatusi's boy, and my Oga Patapata, our father is here, Professor Asuzu. And they taught us so many things. The truth of the matter is that for the first time in our life, as a nation, we realize that we never had a response or we don't have solution to our problem. 19 caught us unaware. The PEPFAR temporary cessation of funds caught us unaware. And I tell you, in the whole of this country, we still not, we probably still need to borrow money, and all of us will need to go hungry. So I think that we should begin to look at it in that aspect. Number 2 is the fact that we need to walk the talk. The ivory tower, if you go to the town with your gown, the community themselves will clear themselves off the way for your own turf. They will allow you to speak and you go back to the ivory tower. You can't afford to go to the town with your gown. It means that you have to come down to their level. And this is where I'm going. The fact that if you look at in the last 25 years, we have had 10 ministers of health who are professionals in health. Out of the 10, 8 of them were people who are core health workers. And if you look at the impact of all of them, you'll just be sorry at the end of the day that we did not make any impact. We talked about revitalization of PAC and everything. The outcome is what we already know, you know. So if the people at in authority, if we occupy the place of authority and we cannot impact health, then it means that there's a problem. And I think the problem is this, is the fact that we are not that we are supposed to speak. In Nigeria here, as far as Nigeria is concerned, government is the holder of resources. Primarily, they are the holder of the entire resources of the country. So it means that for us to make a success of community health, because that's part of our reality, for us to make success of community health, it means that we have to speak to those people who are holding the phone. And how do we speak to them? We must speak to them in their language. It means that the gown and the community must speak the language, must make themselves to be electorally significant. They must be able to present the fact that they are of value, electoral value, let me put it that way, for them to be able to get resources. If Professor Fatusi and Professor Asuzu go to the governor now, they will welcome them, they will laugh, they will leave that place with promises that may never be fulfilled. But I don't know which politician is here, go to that place of responsibility. Make the people understand that public health or community health is not bread and butter. If you train them as bread and butter people, they will go back and give bread and butter services, and at the end of the day, we will not be able to retain them. Finally, let me conclude, sir. Having looked at the presentation today, he reminds me of the Bamako initiative and the failure of Bamako initiative. The problem that led to the failure of Bamako initiative is still existing. SAP was one major problem that we had in this country, privatization of the health system. And we have yet to deprivatize, such that people now still pay out of their pocket. And unfortunately, once that happens, it excludes all those people that are poor. Our health insurance, how much have they taken care of the indigent and the poor, rest of the poor? What coverage do we have for them? Except for the pittance that is being handed out. And a lot of time, of course, if you look at this, you know, of course, you have systematically, you have excluded them. People have talked about community health insurance. How sustainable? When the proportion of people that are poor in this country, you know, multidimensional poverty, I don't know what the new rate is, but we used to know that it's over 70%. So if 70% of your population are in poverty, you know, so how then do you expect them to access quality health? And we see that all over the place, increasing maternal mortality and child mortality. Let me close with this, sir, that the result you showed for Ondo State is not the result of what is happening presently. So it's not a reality. Yes, I'm the director of family health. Child health, maternal health is under my purview. What you are seeing is the result of investment that took place years back. And that's why we have to go back to those systems that has worked in the past. Because by another NDHS, it will not be the same story. And one of those things that we have to begin to look at is to look at autonomy. Autonomy for the health system, autonomy for the community. Autonomy for the community in terms of finance. Autonomy for the community in terms of management of the health system itself, with government backing, providing the funding and resources that is needed. All of this must come together for us to be able to advance and make meaningful contribution. And I want to thank Professor Asuzu for keeping steadfast. Although I don't know when Oga will get to Canaan, but I think he has recruited people. I don't know when we will get there, but I think that we will surely get there. Thank you.
Thank you very much, Dr. Ladeni, for your very beautiful contribution. presenters for the day. I hope you're taking notes. So for those that you need to respond to, quite a number of them suggestions. Dr. Akimbodewa, you have the floor now, please.
Thank you very much, the speakers. I want to congratulate Dr. Shumakinwa and Upola for the very lucid presentation. I have questions and comments. My questions to Dr. Shumakinwa. You mentioned home visit by the community nurse midwife. It appears to me during your presentation that she seems to be the only one in that community. So I just want to know, how is she able to achieve that? How long does it take? Who funds her? And who pays the community nurse midwife? Then number two, what's your comment on placement of public health nurses vis-a-vis community or within the teaching or general hospital? Topopola, you mentioned in your definition of public health, you focus more on transmissible infectious diseases. Where is NCD, non-communicable diseases? Then you whet my appetite regarding BHC, PFP, but I guess because of time you skipped it. I would like to know more about that. Innovation, I want to thank Dr. Popola very much, because I think that's what Unimed and Unimed Teaching Hospital is doing right now. Let me appreciate Dr. Ademujimi. Aladini. Okay. But here it is. I want to appreciate you because you pointed our attention again to the traditional problems, which I always know we can't solve in this room, because the politicians are not here. I think they should have been here to listen and see what exactly we have in mind. But we can still visit them like we've been advised. But for as long as we're here, we can still look at what is within our capacity. And I want to appreciate Unimed for that. For example, I want to look at the Australia model. They have been sending their students for rural 6 weeks. Compensation for doctors and nurses who wish to work in the village. Then, business modeling. The service delivery to many of us, like Dr. Shumakiwa said, seems to be more of, I think it's Prof, the VC, that said we only wait for patients to be sick before we rescue, and that we should actually be with them in the community, and I agree. I'm the consultant there, well, give me 50% of the revenue. So I take care of the people, and I'm making money, and it's a threefold thing. We make money for the consumables and materials, people. We make money to service the person working there. So I think we can achieve that at our level. And then we can show the government that, like we have been saying, that instead of seeing health sector as a burden or liability, that it can make money from it and, gain some political advantage. Thank you.
Thank you, Dr. Akimbodewa, for your contribution. So before we take the responses to the question, Dr. Odikwe.
Thank you, sirs. Standing on the existing protocol, I would want to comment and ask a question. And the question is, with respect to the challenging thoughts from the Vice Chancellor and my honorable speakers, to Dr. Popola and everyone, the question is, if we are to look at the delivery and the end goal of this project, or the end goal of this scheme, is to make the world a better place. And if we are dealing with that, I would want to ask the question of how do we incorporate other aspects of public health? Let's be realistic. Now, we all know prevention is better than cure. I'm saying this because I'm a doctor of environmental health. So, and I understand that most of the diseases trending, be them pandemic, be them Lassa fever and all of this stuff, malaria, they are all tied down to the environment. In fact, the school of thought believes the first set of defense in quality health is human immunity and the environment. The immunity will come from nutrition and things like that. So how do we incorporate all the Unimed has a lot of all of these fields. We have the Department of Nutrition and Dietetics, we have HIM, we have community health, and so on. So I would want us to bring in other public health, at least from the definition of public health. It's not just the treatment and so on. It's about making the world better across fields. So I just want to say we bring in more fields of public health and professionals. Thank you.
Thank you very much, Dr. Odipe, for that question. So before I allow the speakers to respond to the question, I want to quickly just say something about what Dr. Odipe mentioned. So that's why we're here today. How do we integrate everybody, the medical, other health profession, other public health specialties into ICHI? And you can always go and meet Dr. Shumakiwa, register your presence. When Professor Asuzu was talking, he said he wants everybody. He mentioned the agriculturists, he mentioned someone else. So everybody is needed to make the world a better place. So you can kindly register your presence. Everybody in this room, we can all make the world a better place. So over to our presenters. Thank you. Yes, I'll take another round. Yes, I'll take another round of questions.
Thank you. I think I can just stay here. Dr. Aladini, for your vital comments, and most of the things you said, not really a question, but comments for consideration. You talked about funding as well, which also occurred in the comments of Dr. Akimbodewa. For the question asked by Dr. Akimbodewa, you said community nurse midwife. We have only one at Okegbo. How is she able to cope? Yeah. After the medical examinations and established the at-risk register, I showed that slide of scheduling periodicity of visit depending on the severity of the disease condition per time. And some of them maybe just once or twice in a year. If it's not a very serious case, and it's be maintained on the control measures. But also, I agree with you that the world is quite large, and one of the things that the community nurse midwife has also done is to, at her level, engage another community health worker, supporting her to do the work. And of course, some of the follow-up also involve phone calls and then for those that she needs to visit, as scheduled, she should visit them. By and large, with those strategies, she's been able to cope and to follow up. The follow-up is not exactly doing it as touching everybody at the same time. So it's scheduled, it's spaced, and we know per month or per time, you know who and who you are going to see, and then you plan your time, and you place those that she'll call, those that she'll visit, and then those she'll invite to see her at the head facility. Because she spends 3 days at the clinic and 2 days at the head facility each week. For the business modeling, I think that public health nurses. It's if we what the program what we the woman we engage.
Thank you so much. Thank you for the questions. I have to ask one of them. I didn't catch all of it. Public health nurses can be reoriented to do community nursing practice. You know, the models that we have. I understand the National Association of Nigerian, the National Council, I think, has a community nursing program. I don't know what it entails. I have text in which the practice is taking place. So if you get a public health nurse who is open to the idea of walking into people's dirty houses, doing home visits, sitting down with people, they offer you water, food, once you are oriented towards that and open to it, they can actually do the functions. It's not a skill gap. It's actually more of an orientation and seeing that it can be practiced in this manner. The question about down to town, yes, absolutely true. I don't know any meeting where I've ever gone to and seen politicians, except the ones that are called by strategic partners or international partners, with good reason. Anybody who has, Professor Fatisi has sat down here, his laptop is on because there are several things he needs to be doing while we are saying all this, you know, and I know Prof doesn't sleep. He hasn't slept in the over 20 years that I've known him. One of my endearing memories of him was, I went for a training when he was at Ife, and I saw him at 5 p.m. and we were gisting. And he had a grant he was submitting that night that he was going to meet with. And I was like, you have a grant that's closing this night, and you're gisting with me and under no pressure. And that's just how he's lived his life. But let me tell you a story about down to town that a friend of mine told me. 80% of my colleagues that I graduated medical school with live abroad. So one of them told me that in his state, that they have dialysis for people who have chronic kidney disease, free dialysis. And how did that happen? A state senator had a daughter who developed chronic kidney disease. And then he watched his daughter go through that entire course. So when he finished, he said, no, this state is going to pass legislation, dialysis care must become free. So he's in a situation where he sees diabetics and hypertensives who are not on Medicaid, Medicare. He can't treat them. But when they develop kidney failure, he can dialyze them. So change happens. I found out that what really changes the world is not this symposia, these big meetings. It's private conversations and lived experiences. If you talk to someone, if someone in political power is asking, what do I need to do? And you sit there and say, look, I went for a symposium in Fed. They did this, they're doing this model. Call someone, that happens. That's how change happens. So that's what this symposium is about, to say that these things that we're talking about, even we medical practitioners don't understand it. We don't get it. Once we get into office, there's 17 billion. You now go and show your governor, 17 billion, Kileko. There's no building. There's no paint. I didn't do commissioning. You know, you stole the money now. That's what it means. You gave some people, they walked around, who saw them. You know? It looks like a lot of hidden activity. So it's actually a reorientation. That's what I was telling Dr. Shumakinwa, that I think the cost benefits, the cost effect analysis is actually a very big thing to put out. To say even if it's 50% more, but this is what it produces. It's a really big argument to make. I think that if we can't become politicians. If we become politicians, we'll stop being scientists because there are two different skill sets. Very few people can manage both of them. But I think that the bridging points for these conversations and activities are the technocrats in government like yourselves, politicians, and the bridging points. What I have found in a lot of meetings when I go is that, especially when they're strategic level meetings, the agenda has been set already. I've been in a meeting with a governor where someone said something, he didn't like the way it sounded, and they practically walked him out of the meeting. So even me, when I don't go for college board in UI. They told me only professors talk in UI. I said, until I become professor, I'm not going. They should say whatever they are saying there. Yes, no, I'm not. That's their own problem. That's the culture. So what I'm trying to make is that the culture of the space is, if we understand it, we can begin to noise it abroad. The more people who momentum things like this can develop. Like standing up from here, one of the things we should be saying is, the community nurse midwives that are existent in the pilot local governments, can they get on the local government budgets fully? Can we have a conversation, MNCH project, can you put them on the state budgets? SPHCDA, can you fund this activity? Even within existing income streams, that's how these things become sustainable. That's how people remember. If not, when Professor Suzu dies, Dr. Shumakinwa moves to Canada with his family, nobody remembers. And that's been the history of a lot of the work that has taken place. Sorry, 1 minute. Sorry, I was writing notes here. I didn't bring a pen, so I had to write it on my computer. Sir, in talking about NCDs, the definition I provided was from C.L. Winslow in 1923. So it looks like a lot of it's about non-communicable diseases, but the principles are the same. What are you going to do to address non-communicable diseases? Health education about how people live, and then organizing health services so that people get early screening. So the principles cut across completely. Sorry, I didn't get the second question you asked, sir. That I went to. Okay, BHCPF. Okay, Basic Healthcare Provision Fund. So the Basic Healthcare Provision Fund is an allowance within the National Health Act that allows the government to fund public health directly. I think 2% of the revenue. So that's actually what has driven the creation of state primary healthcare development agencies, because that's the avenue by which they can access that fund. So that's why state primary healthcare development agencies have funds to support local government. So a lot of work that you see, local government health facilities, sometimes doctors being employed, they're actually being supported by funds from the state primary healthcare development agency. And is this BHCPF fund? So consequently, maybe when local government autonomy happens and then local governments start to control their budgets, we can have more and more about this kind of conversations. That's something I'm really looking forward to. I hope it will make an impact. Innovation comments, business models, absolutely correct, sir. These are some of the things we need to be thinking about. But at the end of the day, to sell it to any stakeholder, you need to show what the numbers mean. What will this cost at the end of the day? What does it add to our health budget? You can't do it large scale, but perhaps pilots like the Institute has done are some of the ways to go. Like I said before, we need to think about new solutions. What you said, what happens with a lot of physicians is, you can do certain things at a certain stage in your life. When your kids are going to university and your wife is saying, I want my kids to be educated in Canada, I'm not going to leave you behind, I don't trust you, you are not going to be able to run this model. So people can do it when they are younger, they don't have a lot of responsibility. There's a lot that goes into it, and then there's personal proclivities. I think that one of the things that we should really be talking and looking about more, especially with community health work, is harvest people from those communities. Some people come from their community, they would not leave that community. So actually, if you identify them early, and the funny thing is how time works. This project started in 2019. This is 2025. So that's 6 years ago. If you found someone who was 17, 18 years old then, that person is 22, 23. In another 4 years, that person will be almost 30, you see? And if you bring in the right people who are invested and located within the community with long-tending roots, I think they tend to stay, and these things will be more sustainable from the human capacity standpoint. Thank you so much.
Thank you for your responses. So because of time, we'll take the second batch and the last batch, actually, of responses and questions. 3 persons as well. Okay, so I have somebody from here. Dr. Adeboye. Yes. Any other? Oh, okay. My Vice Chancellor is raising up his hand, so I don't have a choice. I have to allow my Vice Chancellor to talk.
My master's in public health, and I finished in the years. Professor M.C. Asuzu. They call it community health then. Later it became community medicine. I did health promotion, health education. And so I'm really very comfortable and happy to be here. Okay, so what I want to make a comment on and challenge on is the fact that communities, as soon as I'm a pharmacist by profession, so maybe you want to say that pharmacy is not really within public health, but being an health promoter and an health educator as a result of my master's in public health. So I find myself really operating in that space by myself. So what I want to say is, most doctors and maybe people in my own cadre as well, we don't even interact with the people on our street. They don't even know us. Once we just wear the suit and we enter the big car and we go out, even when people have problems, they don't know. I know that there are a few doctors who have made impact like that. And I knew one doctor at, is it Lanlate or Erua in those days? Maybe some of us can remember his name, who was really in his community and was making a lot of impact on the people. And I know that if we are going to change the narrative, we have to start from when the students are in school. Dr. Popola was talking about raising people from the community. But do you know that by the time we raise them from the community and we bring them into the university system and we put shoulders on their paths, they are not going to even remember that community. And many of them are going to see people in the community, just like Dr. Popola saw a farmer who was a colleague of his father in secondary school, and, think that, this could have been me also. So we need to, as lecturers and as healthcare providers, put it into they are there, that we need the people. We need the people. Otherwise, what we know in the gown, we won't be able to dispense it in the town. And I'm sure as I'm saying it, many of us they don't give even to the immediate community treatment. It's not about the treatment, the drugs, the surgery and all that. Yes, it's part of it. But people's mind must be changed. People's behavior towards health must be changed. And the community, therefore, will now become healthy. This is very important as we walk out of here. Thank you very much.
Thank you very much, Dr. Ajala, for that challenge. So what impact are you making in the community? What impact am I making in the community? I'm sorry, we might not be able to take, because of time. I think we are far behind schedule. So the conversation and the discussion can continue after here. So I'll move on to Dr. Adeboye.
Thank you. The Vice Chancellor and the principal officers of the university, let me be brief. The traditional rulers here present and chiefs, and the academics around, and all the members of this gathering. Respected ladies and gentlemen, let me appreciate the university as well as the Institute of Community Health Innovation and Development of this university. This one being I think it's the first University of Medical Sciences in Nigeria, if not West Africa. We thank the people that were behind it. They did a lot of job. I can see some of them here. Thank you so much. Yeah, most of the things that I was spoken about have been taken, most especially by these my two brothers. But I will still go just in a sort of a small, or coming down. Because he who has head has hope. And that one that has hope has everything. That's the Arabian proverb. And health is the best wealth. And by community, the approach is community health. Because most of the diseases that kill, they kill not because there are no doctors to treat them, but because either there's nowhere to go, or they themselves, they don't go there. The health-seeking behavior is low. But with community participation, change of mindset, as I said, mobilization, education, people close to them. Now, we are here. When you give them the letter, it's already there. But what you see is that everybody wants to stay in Akure. If you know the town, none wants to go to Ilututu. Though, okay, but if you don't come, we have more than, it's the center of civilization. We have more than enough there. But it's important, please, HMB, sir, if you can review the policy, let's have it that a health worker, you have to go to the rural area for 2 years out of your service years. With that, we will have quite a robust health service to the community. and tell the community people to provide accommodation and some amenities, which will be provided. We in our community will build a bungalow for them, and with water, with television, with everything. Confidence is there. So it's important, please, if you can make use of it. Secondly, thank you, the university too. We have the academics, the gurus are here. So it could be part of the postgraduate training now, that even people that are residents in Unimed, you have to spend 3 months in, go 3 months in this thing. Maybe faculty of pediatrics, faculty of internal medicine, faculties of and gynae, and all those ones. If we do that, they come there, the people working there will have the new methods, new innovation, they will be trained, and that's capacity building. They have talked about it, but the jamboree that we usually organize, we are doing this, you pay 300,000. The government will pay 1 million per head. It doesn't work. Please, let us look at it with the various colleges. I think there are 2 postgraduate colleges. We can put it. If those in Ondo will be sending to the rural areas, if I will be sending there. I think Faculty of Pediatrics, West African College of Physicians did it one time. I don't think maybe they cannot continue it. I remember Professor Lete Lucian did a nice job there. We gave them an accommodation. So please, let's look into that. Thank you so much.
Thank you very much for that useful contribution, Dr. Adeboye. So a word for our policy makers. They are here seated, and also the various faculties. I know in community medicine, our residents go to the rural posting, during their junior posting, the senior posting. So other faculties too, so you can key into this. So we have a comment, sir. Yeah. Please, can you help pass the mic to him? Miss Wumi, please, can you help?
Good afternoon, everybody. I would like to stand on the already established protocol. My own discussion is about the topic for the day, which is Unimed and community service. Looking at the presentations here today, the discussions have narrowed down onto public health contributions to the community. But when you look at that word community service, I think it's broader than that. And we have to start, my own point is to start from the university community. Because the university also is a community. And they say charity begins at home. So my poster is this. What is the standard of behavior in the university community? Taking Unimed as a case study. Then the students, how early are they incorporated to learn innovatively in contributing to these community services? I think these ones will go a long way in also projecting into the future. Because now most of us here are adults, and most of us have carved our niche in our various areas. So I think catching them young also will help to take the gown to town. Thank you very much.
Thank you very much for that. So my Vice Chancellor. Can I bring it to you?
Sir, Dr. Ladini.
Okay.
Thank you, sir. Just a question. And thank you, Poppy. I thought I was going to be here before you start, as if she was. Popola is one of my great friends and great colleagues, and I'm glad to see him in Ondo. My question, Dr. Shumakiwa, we've been on this path for 5.5 and a half, almost 6 years. The university pays salaries to community health nurses. We were going to do a survey a few months ago. You brought me a bill of over 100,000 or 200. I can't remember how many people are going. I have to pay allowance, I have to fuel. How do you hope to sustain this for the future? When a new vice chancellor comes, and if he or she has a different orientation, will this go the way Ibarapa went when the Rockefeller project money got withdrawn? If you have a new vice chancellor and it's even more enthusiastic than all the people you have had, and it goes on, what happens if the next one after that is not as enthusiastic and thinks that, look, my statutory duty is to pay my staff, not pay one man who is sitting down in Lututu or in Okigbo. What is the pathway for sustainability for all that have happened? Number two, how do you document, maintain this instant memory that Dr. Pola speak about? I will stop at that. Of course, I have probably many more questions, but I'll start this too.
Thank you very much for your question. So over to our speakers for today, Dr. Pupola and Dr. All right, okay. I don't.
Intersectoral collaboration for health. Public health nursing is practiced in two paradigms. Anybody who has studied the British health system, the Netherlands, Cuba, Fiji Islands, Seychelles, a few countries that have applied those models. Nurses and midwives, when they first qualify with their public health nursing, they are in physical health facilities. And if they are, for example, servicing the pediatrician, and they see a malnourished child, who the pediatrician asked her, he said, my mother-in-law won't allow the child to eat beans. They will send the public health nurse to follow the patient home, to intervene in the house. And she comes back. And they have women who say they won't come to hospital. They want to deliver at home. But we can tell them in hospital when they are ready. Isaac Oluwole started domiciliary midwifery in Lagos. You can send a midwife to go there at the house and deliver them with their kids. These are public health nursing and public health midwifery. It's different from the community nurse. It's a public health nurse midwife who is posted statutorily to a clearly defined community under the law. And she's responsible for safe pregnancy, child, everything. So she's there in the community and she does everything everybody does in public health and clinical medicine. These people that they are visiting, that you have done a whole lifelong healthcare planning and decided how adequate is the healthcare they are getting from the physician or the psychiatrist. So are they going to visit them fortnightly or monthly or every other month? That's what determines the periodicity. That somebody in the house is trained as auxiliary nurse who can deliver their medicines to them or make sure they walk if they are hypertensive or eat a lot of fruits, nuts, and vegetables. Who must be at home when she visits to give account as the nurses will give when you are doing ward round. This is what a community nurse midwife does. Even though the people she's visiting are the people on at-risk register, when she sees somebody poo-pooing on the street, in the bush nearby, he say, Mommy, why are you doing that? Or Daddy, why are you doing that? He hold me quickly. Okay, if you want to do that, dig the ground, clear the ground, so when you finish, you cover it. Otherwise, flies are going to hop on it and go and infect other people's food. You know? But, and encourage government, do public toilets where people can go. That's what she does. If she's a woman force-feeding the child, say, why are you force-feeding the child? He said he doesn't want to eat. If a child doesn't want to eat, he needs either petting or is sick, you take to the hospital. You kill this child, 9 months, you'll be in danger of death every pregnancy. That's what she does. But those are things that arise as she goes. But her target is those chronically ill people that they are living at the maximum level of health for themselves. That's what her job is. And she's there two days in the health center. So it's very senior nurses who have had the widest public health nursing and midwifery experience in the physical facilities that are posted as those. And they are very senior nurses, and they are paid properly. In Fiji Islands, teaching the school of medical school, and the medical officer of the local government. On Monday when I arrived there, the nurses bring their claim forms for the bus they use to visit the communities. I will sign it before 12 midday. Because Fiji pays fortnightly, they will pay this money, the money they use for transport, before they pay salaries. You know, so the function of a statutory community nurse midwife is different from vertical public health nurse domiciliary. No, she's in the community, and everybody knows her. I can't go to the community as a medical observer. Every physical facility that doesn't have a doctor or a medical assistant, I must visit it either monthly or 2 monthly or 3. And I told them that in Ondo local government when we are doing the primary health care ransom kuti time. When I'm only going to go, like, okay, I'm going to go there tomorrow. On Tuesday or Thursday, when she's at physical facility, when she's visiting the community. So if you're a health educator, you can't go there except on days she's available. If you're a nutritionist, anybody who wants to do anything there. And when you come there, you are looking for what do you call, pediatric surgeon said, he will come and train the statutory community nurse midwife so that she will go inspect every child at birth to find out the pediatric surgical issues that children come at birth. So when you do community anything, we know the total population in need of your service, whether it's environmental health or nutrition or health education or diabetes. We know the total population. So if you do 5, we know you do 5 out of 10 or 5 out of 100. We must know the percentage coverage you have given. So the paradigms are different. And what we are doing is not that the whole state can do it. No, demonstrate. Another one, and that one goes, and you go to meet the second one goes, and you go to meet the second one. Promises?
Thank you, Professor Asuzu, for helping to differentiate again the difference between public health nurses and community nurse midwife. We always appreciate you. So our speakers for today, can we respond to the outstanding questions?
Sorry.
Quite a number of suggestions. Let's just respond to the questions that were posed.
The
Thank
VC
you.
asked 2 questions. The issue of salary sustainability for the community nurse midwife, I address it, and institutional memory for, honestly, that is it's a very important question. Institutionalize this, which I believe that's been done. The fact that the community nurse midwife, they are employed by the university, except the university, the new Vice Chancellor want to say, oh, this is not a concern. But I think the fact that this program addresses a core component of the vision and mission statement of the university, which is community service. One will expect that. So maybe going forward, that will be neat. Thank God the Unimed CMD will continue to be on ground, even after the exit of the current, and he has shown a great deal of interest and commitment. So we'll be leveraging also his good office to advocate and now kind of a joint venture between the Unimed and Unimedth. I want to believe he will be in a place to iron out those among themselves at that level to see how we continue to sustain those institutional memory. I think one of the ways is perhaps to ensure that there is publications of the activities of this program going forward, and of course ensure that we integrate this perhaps into the curriculum of the medical student, or as part of their components of community health, and that is aside. That's my understanding of, at least for a way of going forward on this.
Thank you, Dr. Shumakinwa. One or two words from Dr.
Thank you so much. One of the privileges as an outsider is that sometimes maybe you can say things that insiders can't say. I'm going to get into my car and run away, and nobody can chase me after when I'm gone. I think that, as the VC said, sustainability is vitally important. And the lesson that I learned watching Professor Asuzu at the Barakwa program is that MOUs are only as good as the people you are writing them with. And those people change. I think I said twice that this needs to get on. and that is the truth. It needs to be on someone's budget who has inflow. Whether that is the office of the provost, which academic board meeting, we will fund this like this 5 years, so that when you don't pay it, that director, if he's ready to fight the provost, will say, I have an existing agreement, you must do this. Easier, the teaching hospital budget, there's constant inflow on that, although everybody says inflow is not, it doesn't meet what I need to do, but it must go on someone's budget. At the end of the day, ideally, I think this really should be on the local government's budget, if the local government has bought into this model. If the director MNCH, the local government is going to say, we have this pilot, we are running in conjunction with the hospital, this is what it's producing, then they must be also ready to say, within reason, even if they can't carry the entire thing, even if it's okay, we are giving you 300,000 annually for survey-related activities for this project, you can pull on it. We have 100,000 for training. When you need to do trainings, that resource is there. Or we are taking over the salary, or we are providing transportation. Someone needs to be responsible, and sir, you must do it before you go. Otherwise, if another king comes that does not know the face of, maybe then I would have prevented to my provost, and then when he says we should come and see it, we'll now be chopping mouth, like we do sometimes with our program, and showing people pictures. We did this, we used to do this. Thank you so much, sir.
Thank you very much, Dr. Bukola, for that, and the two speakers. I'm sure we'll had a nice time doing this discussion, so I won't want the discussion, the conversation to end here. Let's continue, and so that at the end of the day, we'll be able to leave things better than we found them, just like Dr. Bukola said during his presentation. Thank you very much.
Please let's put our hands together for Dr. Oladoyin. She has done a very good job, and we want to appreciate all the speakers too and the contributors. This has actually been very stimulating. It has been a great time together today, and we know our time is fast spent. We want to appreciate you. We are going to be closing the program with this interaction that we have had. And I can assure you all the points have been noted. We will put all the points together and ensure that the discussion does not end in this hall. We'll put it out there so that it becomes an